So today we're going to talk about benign breast disease. Um, it's a little bit of an artificial division of subject matter, and so I am going to take liberties with it and tell you some of the things that I learned studying for this and sort of getting into the nitty-gritty. Um, I hope you think it's interesting the way I did. So the microanatomy of the breast um, has segmental ducts that empty uh, into the nipple, of course, and these segmental ducts have these ampullae or lactiferous sinuses that are kind of under the nipple areolar complex. They have elastin so they can distend and fill with milk during lactation, and they have smooth muscle elements around them that will help them contract. Then as you get more peripherally in the breast, you get into segmental ducts, or the ducts are branching and ramifying. And then finally you end in the terminal ductal lobular unit. And this is abbreviated TDLU, and you have to know that abbreviation if you read breast literature because TDLU is a thing. This is a micrograph of a TDLU, and here is the terminal duct and the terminal duct lumen, and then these cul-de-sacs out here are the end, and that's the TDLU. Now, the epithelium of the duct of this structure that we're talking about, whether it be segmental ducts or the TDLU, is shown here. You can see the lumen here, and these are ductal cells. And the duct epithelium is made of these ductal cells. The duct epithelium is normally 2 cells deep. There are luminal cells, which end over here at the lumen, and then there are these deeper cells that are more basilar in position, basal cells or myoepithelial cells. Myoepithelial cells do not secrete, but they are part of the epithelium. These ductal cells, they do secrete, and they are luminal cells. Okay, now when I say the myoepithelial cells are basilar in position, it doesn't necessarily mean that they are basal cells. When people talk of basal cells in the duct epithelium, they talk of the progenitor cells or precursor cells that are pluripotent stem cells that can differentiate into luminal cells, which secrete, or myoepithelial cells, which do not secrete. They have actin and myosin in them, and they can squeeze. Okay, so this gets very confusing because we talk about breast cancer subtypes, luminal types, luminal type A, type B, basal types, and these are all descriptions of where maybe these cells come from, their cell lines in cell cultures that people do experiments on when they're studying breast cancer. But they also tend to have a phenotypic expression, so that luminal cells tend to express hormonal receptors like ER and PR. They tend to be ER and PR positive. And basilar cells or myoepithelial cells tend not to be so much. And so, like a triple negative breast cancer would be a basilar subtype more often. Okay, but I'm getting into breast cancer, and this is supposed to be a talk about benign stuff. So let's keep going with the normal histology. The myoepithelial cells actually maintain the basement membrane. which is a bunch of collagen and other stuff out here, which is the basement membrane. Some people talk as if the myoepithelial cells are actually part of the basal membrane, and you'll see that in the literature sometimes, and it gets confusing to me, but really not. They're epithelial cells. They're just a deeper layer of epithelial cells. They also influence the luminal cells. They help them maintain their polarity. Why do they need polarity? Well, they only secrete into the lumen. You don't want them secreting backwards into the deeper layers of the epithelium. Okay, out here around the duct epithelium, the ductal epithelium, out here are stromal elements, the breast stroma. The stroma has stuff like elastin and collagen and fibroblasts. I think these are fibroblasts, these, yeah, spindle-shaped cells, etc. There are blood vessels in them. You can have neoplasms in the stroma as well as the ductal epithelium. Now, most breast cancers, ductal cancers and lobular cancers, arise in the ductal epithelium, but things like fibroadenomas or stromal cell tumors arise out here in the stroma. Okay. This is a stain that pathologists are fond of putting up in breast conference because this is a special stain for myoepithelial cells. Myoepithelial cells can be hard to see. Myoepithelial cells are kind of a surrogate marker for the basement membrane, even though they're not really the basement membrane. This leads to a lot of confusion on my part. The myoepithelial cells are a loose network. They're holes in the myoepithelial cell layer. It's like a mesh. But on the other side of the myoepithelial cells is a basement membrane. So they will put this stain up to see a lot of times if a clonal population of cells growing in the duct epithelium is DCIS, carcinoma in situ, limited to the duct epithelium and not invading past the basement membrane. The myoepithelial cell isn't really the basement membrane, but they use this as a marker because it takes up stains to things like cytokeratin or smooth muscle actin and myosin, things like that. So they will stain these cells and they'll say, this clearly is within the duct, it's DCIS. But again, we're talking about benign disease. I have to remember that. Okay, here is another micrograph showing a lobule, and then these are the ducts. Okay, so the lobules are just fine branches of the terminal ductule. And these end cul-de-sacs are sometimes called ductules. So my question for you, this is a rhetorical question, so to get you to think about things. What is the difference between an acinus and a lobule? And what's an acinus anyways? And what's a ductule? Okay, that's long enough to think about it. So let's see. Okay, in this diagram, you see a segmental duct, and then this whole thing here is a terminal ductal lobular unit, this whole thing. So this is the terminal ductule, and then where it branches into all these little branches, these are the lobule. This together is the lobule. Now, all of the epithelium in this terminal ductule is secretory. And all the epithelium, of course, in the lobule is secretory. And these are not that well developed all the time in the breast. They are very well developed in a lactating breast, but not so much in a quiescent breast. And they're developed to different degrees during the menstrual cycle because this is all hormonally sensitive. The duct epithelium out here looks the same in the segmental duct, but it does not secrete. So I ask the medical students all the time, It would only make sense that ductal cancers start out here in the duct epithelium and lobular cancers start here in the lobule, right? That's a rhetorical question. No, that turns out to be wrong. Ductal and lobular cancers just describe a growth pattern. Those terms describe a growth pattern and don't really reference where the cancer population of cells, where the clone of cells arises from. Most cancers, the great majority of cancers, arise from the terminal ductal lobular unit, from these pluripotent stem cells, these basaloid cells, and then they differentiate to different degrees and look like luminal epithelial cells, and they arrange themselves in either a ductular pattern or a lobular pattern, and under the microscope, they look like ducts if the cells stick together and arrange themselves like ducts, and then they're called ductal cancers because of the way they look, or they just kind of stream all through the stroma and they're not adhering, and then they're called lobular cancers because of the way they look. And if they can't tell, they'll put a stain on them like E-cadherin, which is a marker for an adhesion molecule. And if E-cadherin is positive and the cells are adhering together and making ducts, it's a ductal cancer. And if it's E-cadherin negative, it's lobular cancer. But again, we're talking about benign breast disease. Okay. So here is a diagram that I think is useful. It's very much oversimplified, but it's a good skeleton to hang your understanding on. The normal ductal epithelium has these orange cells, which are myoepithelial cells, and then luminal cells, which are somewhat regular. They all look alike. They have small nuclei and they have the same shape. They are typical. They are just your typical ordinary epithelial cells. Sometimes, like at certain times of the month in a reproductive age female, the epithelium is stimulated and actually grows or multiplies, becomes hyperplastic, okay? So now you have more than one layer of luminal cells. You have multiple layers, okay? These cells look like these cells over here. They look typical. This is ductal hyperplasia, but there's nothing to see here, folks. Move along, because these are typical cells. So there's no concern, okay? Sometimes, though, you can have hyperplasia and the cells are kind of big. Lots of cytoplasm, irregularly shaped. They're funny looking cells and they have funny looking nuclei. These are not typical cells. These cells are atypical. So now we have atypical ductal hyperplasia. Is this worrisome? Well, a little bit. I'd rather have typical ductal hyperplasia, but atypical ductal hyperplasia, nothing really life-threatening here, at least not yet. Now, occasionally we'll cut through ducts under the microscope and we'll see lots and lots of atypical cells. They are all piling up along the epithelium within the lumen of the duct. You can see the myoepithelial cell layer, which is the surrogate for the basement membrane, is intact here. But there's so much of this that we call it DCIS. The difference between DCIS and atypical ductal hyperplasia is both quantitative and qualitative. Now, quantitative meaning that if you have more than 2 millimeters measured on the microscope slide of atypical ductal hyperplasia, that meets the criteria for DCIS. That's too much atypia to just call it ADH, atypical ductal hyperplasia. So more than 2 millimeters is DCIS, or more than 2 lobular units is DCIS. I don't really know how they tell if it's more than 2 lobular units, but that's the quantitative difference. Now, they can also tell by nuclear grade. Smart pathologists and cytologists will look at these cells and they'll say sometimes, I don't care how much there is here. These cells are too funny looking to be ADH. This is DCIS. So that's a qualitative difference. So you can make the diagnosis either way. And then finally, when you have funny looking cells that actually go through the basement layer of myoepithelial cells, through the basement membrane, out into the stroma, and they're growing out in the stroma, this is invasive ductal carcinoma, IDC. Now, just an aside here. An older term for DCIS is intraductal carcinoma. I have people in the clinic all the time come up to me and tell me about a lady who got chemotherapy for her intraductal carcinoma. Most people don't get chemotherapy for intraductal carcinoma. So I know right away that they're confusing IDC, invasive duct cancer, for IDC, intraductal carcinoma. Intraductal carcinoma is not a good term. It's sort of been abandoned. So don't say intraductal carcinoma, because if you do, people are going to know you're confused about what you're talking about. It's DCIS. Okay, let's talk about some benign lesions with this background. So a lot of benign lesions are significant because they must be distinguished from malignant lesions. Obviously, we don't like to go lopping off breasts for a benign lesion because most people like breasts and they don't want to just amputate body parts for benign reasons. So one of the ways benign lesions can cause concern is when they present in the same way as a malignant lesion. So one of these benign lesions is a radial scar, or when a radial scar is big, it's called a complex sclerosing lesion. But a radial scar can present as a spiculated mass on a mammogram. Now, a spiculated mass on a mammogram is generally a BI-RADS 5 or probably malignant lesion. And so here is a mammogram of a radial scar, and it's put up right next to the micrograph, the photomicrograph of the specimen. And a radial scar has a core of dense scar tissue, and then surrounding, there's some disorganized ducts, disorganized breast epithelium and ducts. And it's not atypical, it's just kind of disorganized and arranged in a funny way. This is a benign lesion, but it looks malignant on a mammogram. So when they see this on a mammogram, they'll stick a core needle in it and do a core needle biopsy. And when the pathologist looks at it, he'll say, well, this is a radial scar. The problem is, we know from past experience that if you go in and you do an excisional biopsy, say they do a core biopsy, they leave a clip, and now you go in, you find the clip with a wire or a seed, and you take out that tumor, we will find invasive duct cancer or DCIS. These are lesions that we like to treat. These are lesions with either malignant potential or malignant. We'll find them in like 15% of the time. 15-20% of the time is a high rate of upgrade on excisional biopsy. So when we see radial scar read on a core biopsy lesion, usually the upgrade rate is high enough that we recommend excision for radial scar. So radial scar is a benign lesion, but it can be confused, or it can be confused with a malignant lesion, or we can misattribute the mammogram change to a malignant lesion on a core biopsy, so we like to excise it. Okay, here's another benign breast lesion. It's an intraductal papilloma. Now, the intraductal papilloma, and I have to confess, I'm not exactly sure where it is here, but I think it's this irregular thing in the lumen of this ductogram. So contrast has been injected into the duct through a tiny little catheter going through the duct opening in the nipple, and they take a picture and they see this filling defect in the duct. So that's what an intraductal papilloma looks like. An intraductal papilloma is benign. And on histology, what you see are these papillary projections into the breast lumen, but they have normal epithelium and they have a fibrovascular core. Okay, that's an intraductal papilloma. Intraductal papillomas are benign. A favorite test question is, what is the most common cause of bloody nipple discharge? And the answer is an intraductal papilloma about 90% of the time. But bloody nipple discharge can be a sign of cancer. And so we investigate bloody nipple discharge. If we take tissue and we find an intraductal papilloma, we're happy about that. We've explained the bloody nipple discharge from a well-known benign cause. We don't have to worry about cancer so much. We're going to come back to some of these things, to all these things. Okay, sometimes benign breast lesions can present as a palpable mass or a mass on mammogram or both. So this is a breast hamartoma. A breast hamartoma is all elements of breast tissue, fat, fibrous tissue, stroma, duct, epithelium, glandular tissue, and it's arranged in a disorganized fashion and it has a capsule around it. It has a very typical appearance on mammogram. It's frequently a question because this demarcated area looks just like breast tissue within breast tissue. It's called a breast within a breast. It's a typical mammogram presentation of breast hamartoma. A breast hamartoma is benign. You don't need to do anything about it. If you know that's what it is, and you can tell that's what it is by mammogram, and you can still certainly tell that's what it is by core biopsy. If it presents with a palpable mass, you can take it out if the patient wants it out, but you know, you can pretty much tell her it's a hamartoma and leave it alone. It doesn't have malignant potential. Okay, this is another interesting lesion that presents sometimes as a palpable mass and sometimes as a suspicious mammographic mass, a spiculated mass on mammogram. And it occurs in type 1 diabetics. It's an inflammatory lesion. The inflammation is in the stroma of the breast, the intralobular stroma, and it's diabetic mastopathy. This can be diagnosed reliably on core biopsy. And it does not need to come out, even if there's a palpable mass. You can take it out, but it tends to come back. And so actually, it is recommended that you not take it out. This is a micrograph of PASH. PASH is pseudoangiomatous stromal hyperplasia. The S is for stroma, and this occurs in the stroma of the breast. It occurs in the interlobular stroma, and it has sinuses in it that look like blood vessels, but they're not. That's where the P comes in, pseudoangiomatous stromal hyperplasia. PASH is a benign lesion, but it can look funny on a mammogram. It can cause a mass, and it is frequently found incidentally on a biopsy. And because it has a long and scary name, you will get referrals and you'll get patients who say, I have PASH, I want both my breasts removed. PASH has no malignant potential. Now, this has been debated back and forth over the years, but the current feeling is PASH has no malignant potential. And it doesn't even put you at increased risk for breast cancer. PASH can cause pain, and PASH can cause masses. So are there indications for removing PASH? Yeah, kind of. But when you're operating for pain, you have to be very careful. And if you have a mass and you have a core biopsy showing PASH and nothing else suspicious about it on mammogram or on the path report, you're okay to attribute that to PASH.
And that's Corbin's book.
Okay, so I thought someone had a question, but I couldn't really understand what they were saying, so we'll move
I think
on.
somebody's mic is on, sir.
I understand. I'm trying to be amusing. Okay. This is a photomicrograph of a nipple adenoma. Now, a nipple adenoma, I just learned about it recently because I had a biopsy come back as a nipple adenoma. And the biopsy was of subareolar tissue. And I'm thinking, how can you have a nipple adenoma in the subareolar tissue? But it was an appropriate call. If you have changes that look like intraductal papillomas, and you can imagine these are probably fibrous cores and these are papillary changes in the terminal ducts or in the terminal ducts out near the nipple or in the lactiferous sinuses under the areola. That's called, that kind of papillomatosis, or a single papilloma. In this case, this is, a single papilloma right here. That's a nipple adenoma. A nipple adenoma is benign, but nipple adenomas will grow like adenomas tend to do, and they will even ulcerate the skin of the nipple. Now, what malignant lesion looks like an ulceration of the skin of the nipple? And if you're thinking Paget's disease, that's what I'm getting at. This can look like Paget's disease, but on biopsy, they'll call it a nipple adenoma. Oftentimes you can feel a mass in the nipple. Sometimes you can see it. It's an adenomatous looking thing. It has kind of a glossy, moist appearance at the end of the nipple, and it's a mass, and it should be excised. And if it can be excised with margins, you can sometimes preserve the nipple, depending on how big it is, the adenoma and the nipple, and how deep it is. If you can excise it with margins and preserve the nipple, hooray. And sometimes you can't. It should be excised because it will grow and destroy the nipple, but it has no malignant potential and does not confer a risk. So that's a benign lesion of the nipple that's often confused with Paget's disease of the nipple. Okay, people talk about benign lesions in terms of whether they're proliferative lesions or non-proliferative lesions. This has always been a little bit confusing to me, but proliferative lesions sort of refer back to the hyperplasia-carcinoma type sequence. So the most common non-proliferative lesions, or benign non-proliferative lesions in the breast, are breast cysts. Simple cysts are common in women of ages 35 to 50 years old. Cysts do occur later than that, but the older the woman gets, the more likely she is to have breast cancer just by virtue of her age. So you have to be careful with attributing things to cysts in older women, but older women do get cysts. Cysts are so common. Cysts are present in 37% is what I read of women 35 to 50 years old. And this cystic change that usually waxes and wanes with the menstrual cycle, etc., has been termed in the past fibrocystic disease or fibrocystic change or whatever. And so breast cysts are a common non-proliferative lesion. Breast cysts can be diagnosed on ultrasound, a simple cyst, which means it has a thin wall, no internal echoes, it's unilocular, no nodules associated with it. A simple cyst is benign. You can hang your hat on it. You don't even have to biopsy it. It is an ultrasound diagnosis. Okay, Fat necrosis. Fat necrosis is a non-proliferative lesion. Fat necrosis occurs out in the stroma between the lobules, in the interlobular stroma. Fat necrosis happens from trauma to the breast, which includes surgery on the breast, and it also includes failed fat grafting. Failed fat grafting is the only kind of fat grafting I know about. I don't think I've ever seen successful fat grafting, but the plastic surgeons say it works, and I believe them. I just don't see those patients. So fat necrosis can look really bad on a mammogram. Sometimes it can look like a spiculated mass, and that can be an indication for excision. And there are other indications for excision. I'm going to take a lady to the operating room today who has fat necrosis that's kind of spontaneously draining through her skin and an irradiated breast, which is a big mess. But fat necrosis is benign, and oftentimes it can be confidently called by the mammographer with a characteristic mammographic appearance and ultrasound, and you don't have to go after it, even if it's a palpable mass. And this can be a little bit scary in a lady who's had cancer in that breast already and had an operation there, and she's had radiation, and now you feel kind of a mass in the bed. And if you trust your mammographer and he or she says, oh, this is fat necrosis, hands down, this is a slam dunk fat necrosis, you don't even have to go after it. But I would watch it. I would watch it, because if it's in the bed of the prior resection, and you might look at a couple other things like, you know, was this a triple negative cancer, or was it just a grade 1 estrogen receptor positive cancer, you know, in an older lady? These things all come into play, but fat necrosis is a non-proliferative lesion. We talked about a breast hamartoma. A galactocele. A galactocele is a favorite test question. You'd probably see this more often if you were at a medac hospital instead of a medical center. But in nursing women, they can get keratin plugs in breast ducts, and the milk flow backs up and distends the ductal unit and creates a cystic space that's filled with milk. And that's a galactocele. And they can be very painful. It's the most common cause of a breast mass in a lactating woman. And you can either just have them massage the area, put hot compresses on it, and it resolves spontaneously, or sometimes you can aspirate them. And when you aspirate them with a needle and you get milk back in a lactating woman, you can relax. That's what it is. It walks like a duck, it quacks like a duck. It's a galactocele. Okay, diabetic mastopathy is a non-proliferating lesion. We talked about that. Mammary duct ectasia. Breast ducts can be dilated with inspissated secretions. The last 2 millimeters of ducts as they terminate on the nipple actually have squamous keratin producing epithelium growing down into the duct, and that keratin can produce keratin plugs, cause mammary duct ectasia. It's a benign, non-proliferative lesion. And then pseudoangiomatous stromal hyperplasia, or PASH, non-proliferative lesion. Okay, proliferative lesions like ductal hyperplasia, lobular hyperplasia, intraductal papilloma is a proliferative lesion, and then adenosis, complex sclerosing lesions, nipple adenomas. All these are proliferative lesions, including fibroadenoma, Phyllodes tumors, and this Phyllodes tumor a benign Phyllodes tumor doesn't have metastatic potential, but it can be, it can grow to a large size and destroy breast tissue or compress breast tissue. Okay, we're going to go over some questions here soon, but just a few things on strategies for managing benign breast lesions. It is very important in breast pathology to read the entire path report. Read the whole thing, even though it gets really boring sometimes. Watch for words like atypia, dysplasia, or indeterminate findings. And when you're in doubt, call the pathologist and talk to the pathologist. I don't think I would talk to the pathology resident No offense to residents, but I would talk to the staff
It
pathologist.
doesn't.
Heard about Martinez.
I
Because
know.
you will learn stuff that way.
Try to jump in.
Okay, read the entire
Yeah,
imaging
that would be
report,
good.
and you
If
need
he
to
went
check for
without like
concordance.
resuscitation.
Because, for instance, if the pathology says there's a benign lesion and the biopsy was done for calcifications, say, but this lesion doesn't produce calcifications, it's a benign lesion known not to produce calcifications, then you haven't explained the whole reason you did the biopsy. So that would be a reason for non-concordance. So with a core needle biopsy of the breast, there's always a report for concordance where the radiologist says, yes, this explains my findings, this is concordant, or the radiologist says, no, I'm still worried, this is non-concordant.
I think so. I'm sorry. I'm
How
sorry
much
about that.
tissue was removed with the core? A stereotactic biopsy, that instrument is a 9-gauge needle. A 9-gauge needle takes out like a 3-millimeter plug of tissue. And then a handheld suction biopsy instrument is 12 gauge, still a very large piece of tissue. So how big was the core and how many cores were taken? That helped you assess the risk or determine the confidence with which the call was made on the core biopsy. Because a core biopsy can sometimes remove a lot of tissue or sometimes remove a little bit of tissue. And then you need to know were calcifications recovered, and that's dictated in the pathology report. And that's also dictated in the core biopsy report because they x-ray the specimens, the little cores they put in the machine and they look for calcifications. Then assess the risk of the patient. Okay, and a patient who has a very strong family history for breast cancer, for example, or maybe a prior history of breast cancer, you may be more reluctant to accept a core needle biopsy that's benign. And then, is there a palpable abnormality? Palpable abnormalities in older women generally need to come out and be put in a bottle. And just keep in mind that biopsy is a low-risk procedure. So you don't want to do biopsies that are not indicated. That's not being a good surgeon. But you also want to keep in mind that sometimes doing a biopsy is just the easiest thing to do rather than short interval follow-up, multiple MRIs, and all kinds of stuff. Just biopsy the thing sometimes. It's the right thing to do. Okay. Recommendations for specific lesions. Atypical ductal hyperplasia. The recommendation is to excise, when that's found on a core biopsy, we excise it because a core biopsy usually doesn't remove enough tissue to make the distinction between ADH and DCIS. And in fact, the upgrade rate is upwards of 20% for ADH. So if you get ADH back on a core biopsy, schedule the patient for an image-guided excisional biopsy. And that's true virtually all the time. I mean, that's a pretty hard rule. Now, you would think if ADH is upgraded often, then you would think that atypical lobular hyperplasia would be in the same boat. Well, it's not. Atypical lobular hyperplasia and LCIS, it turns out, are more marker lesions than they are precursor lesions. So a woman with atypical lobular hyperplasia or lobular carcinoma in situ, those terms are now grouped together as lobular neoplasia and are not really distinguished that much. That woman has a high risk for breast cancer in the future, but the risk is almost the same in either breast. Now, there's some new stuff now coming out that some lobular carcinoma in situ may be a precursor lesion, but for the most part, they're considered marker lesions. And so lobular neoplasia is not generally an indication for an excisional biopsy, lobular neoplasia on core biopsy. And it's usually found on core biopsy, and it's usually incidental. Now, there are exceptions to that rule. You can observe lobular neoplasia unless it's not concordant. Lobular neoplasia doesn't cause a spiculated mass. Okay, so you'd have to go over that. You'd have to go get that. And lobular neoplasia usually is not associated with microcalcifications. So if you're trying to explain microcalcifications with lobular neoplasia, no, you haven't explained it. It's a non-concordant result. And sometimes there are other things in the mammogram or on the pathology specimen that require excision or that would push you to excise. So lobular neoplasia is a little bit of a gray area, but the point is you don't have to excise it. There are certain subtypes of lobular neoplasia, though, that you should excise, and that's pleomorphic lobular carcinoma in situ, signet ring cell, apocrine changes, or LCIS with necrosis. You're not going to see those changes with atypical lobular hyperplasia. Those are more with LCIS. Okay, intraductal papilloma. Papillary lesions of the breast are very, very confusing, and I have a question we're going to go over to sort of illustrate that problem. An intraductal papilloma with no atypia that has been well sampled, so I'm throwing in lots of contingencies here, it doesn't need to be excised. This is a big change because in the past, there's literature showing the upgrade rate for intraductal papilloma on core, when it's finally excised, is like between 30 and 40%. So the thought was, if we don't do excisional biopsies for intraductal papilloma, we're going to miss cancers in a lot of women. The more recent data says that if the pathology is concordant with the mammogram, and if the specimen was well sampled, multiple cores or a great big core like a stereotactic biopsy, 9-gauge needle, and if there is no atypia in the epithelium of the papilloma, you can observe that patient. Now, that doesn't mean you cut them loose and you never see them again. So, I would observe that patient, probably follow them out for about a year, but that is a reasonable thing to do. And this is what's done in most breast centers with people who are more specialized, but a lot of intraductal papillomas are excised. A symptomatic intraductal papilloma like bloody nipple discharge, well, you can't, most women don't like bloody nipple discharge. They want it to go away. So you can excise that. And a palpable mass, you can excise that. That's very reasonable, and I would certainly do that. And then we already talked about radial scar or a complex sclerosing lesion. We excise those. Okay. So I want to go to some questions that I thought I had up here, and I'll get them up quickly. Get rid of this. Okay. Let's do this one. Okay, here's a question for you. A 65-year-old woman presents for a screening mammogram. She has no breast complaints, no family history of breast cancer. The mammogram shows a new 5-millimeter cluster of microcalcifications. Diagnostic mammogram shows pleomorphic microcalcifications. Pleomorphic means many shapes. Those are bad microcalcifications. And a mass. Someone did an FNA of this mass because she's on Coumadin for a mitral valve and she hadn't held her Coumadin. Okay, she has a path report in her hand, and she wants to know, is this bad or good or what needs to be done? Because the aspirate smears have some clusters of cells with columnar appearance. They're consistent with a papillary lesion. And since a distinction between a benign and malignant papillary neoplasm can't be made based on just the cytology, they recommend excision. What do you recommend? And they're the choices. And Annalise, for some reason, you're the only person I can see on my screen, so I'm going to call on you.
Sir, I would go with E, bridge to Lovenox with an anesthesia evaluation and perform an image-guided surgical excision biopsy.
Okay, let's see how we do here. We'll check E. We'll go to the critique. Oh, and that is correct. Now, it's the critique, though, that is so interesting, because papillary lesions diagnosed on FNA is that it's almost a useless biopsy. You can have papillary DCIS, and you can have an intraductal papilloma with enough hyperplasia to be called DCIS and an intraductal papilloma, which is obviously atypia, and that would need to be excised. And then you can have something called papillary carcinoma of the breast. And papillary carcinoma can be encapsulated, or it can be just solid papillary carcinoma. And encapsulated papillary carcinoma is such a benign disease that it's staged the same as DCIS. Papillary carcinoma that's encapsulated is T0IS. We don't give chemotherapy for encapsulated papillary carcinoma. We had a patient like that at breast conference a few weeks ago, and somebody said, do you want to get an oncotype? And the answer is no. It's encapsulated papillary carcinoma. It's nothing. And then even unencapsulated papillary carcinoma, it's not quite as good, but it's a little better. Then there's something called invasive micropapillary carcinoma. Invasive micropapillary carcinoma is terrible breast cancer. It has a terrible prognosis. And then you have benign intraductal papillomas with atypia, et cetera. And the point is, with cytology, which gives you no architecture, no histology, you can't really tell. So that patient needs an excisional biopsy. So you just stop Coumadin and do the right thing. So very good. Okay, let's go to another question. Let's see. Let's go to, let's do number 11. Okay. Here's a good one for benign breast disease. You've probably seen women like this in the clinic. Somebody else take this question. I can't see the rest of the participants. Do I have a volunteer?
All the chiefs are on. I see Christina. There's a couple interns. What level do you want, sir?
How about a PGY2?
Christina.
Hi. Here, 46-year-old woman who presents with 6 months of right breast pain unrelated to her menstrual cycle. She does not take any medication, no trauma to the breast, no family history or previous breast pain. There's focal area tenderness in the right breast, no palpable mass or abnormalities. Mammogram and ultrasound are normal, and pain persists despite NSAIDs and supportive bra. Histology.
So a key thing in this question is they're calling this severe mastalgia.
Right.
Okay. So she isn't going to go away with just reassurance.
I think it's A, primrose.
Evening primrose oil. Okay. Patients love that recommendation, by the way,
Oh,
but that's not
no,
the answer.
tamoxifen.
So, of course, people have studied this a lot because everyone is plagued with these patients in the clinic. They have breast pain. No one knows what to do about it. You've investigated. There's no indication for a biopsy or anything like that. What are you going to do? And the point of the question is the only thing that has really been shown to work are tamoxifen and danazol. But danazol makes women grow hair on their face and gives them acne, and danazol is not tolerated well. Tamoxifen has risk. Tamoxifen increases your risk for uterine cancer. Tamoxifen increases your risk for thromboembolic events, even stroke. But for severe breast pain, it's the treatment of choice. And it is effective in some patients. I have never put a patient on tamoxifen for breast pain. I don't know, is any of the other staff? Yeah. Okay. Here's a good one. Let's take, is there a PGY3?
I see
Or
research.
four?
Justin's on.
Okay, great.
We have a 44-year-old healthy woman presents with a new non-palpable right breast nodule found incidentally on screening mammography. Ultrasound examination shows a 2 centimeter by 2 centimeter ovid lesion with low level internal echoes and no Doppler flow, consistent with a cyst containing echogenic debris. What is the recommended follow-up? Let me see the options here. So I would say this is a simple cyst, but does have some echogenic debris. So I think you could do a focused ultrasound in 6, 12, and 24 months. Answer C.
Okay, that's a good answer, but I will quibble with your rationale and some of your terminology. So a simple cyst, by definition, has no internal echoes. It doesn't have debris in it. This is a complicated cyst. So it requires, as a minimum, short interval follow-up, okay? And short interval follow-up is a 2-year process, goes out 24 months, 6, 12, and 24 months. This 3, 6, and 12-month thing, it's not a thing, okay? This is the thing. So let's go to the critique. So it's a complicated cyst because it has internal debris, and the malignancy rate is very low, but because it's a complicated cyst and they see something, they follow it because what's the big deal in just getting another ultrasound at 6, 12, and 24 months? For me, it's worrisome because I don't like to have to follow a patient out for 24 months to complete something, and we don't have the machinery in our clinic to make sure the patients come back. I mean, once a patient walks out of my clinic, I forget they even exist. So we don't see this. Mammography does this for us. So they get a mammogram, and if it's a complicated cyst and they want to do short interval follow-up, they send the lady a letter and they put them in their database and they nag them to come back and do all these things. So that's really nice about practicing breast disease at BAMC. Very good. Okay. Here's a good one. This is a chief resident question.
I think you've got your pick on Chiefs.
Okay, Alex.
Yes, sir. A 48-year-old premenopausal woman with type 1 diabetes mellitus presents with the breast mass. She has no family history of breast cancer. On physical examination, there's a palpable 2.5 centimeter firm, mobile, non-tender mass in the right breast with no axillary lymphadenopathy. There are no overlying skin changes. Bilateral mammogram shows dense tissue, and ultrasound shows an irregular hypoechoic lesion with posterior shadowing. Core biopsy is performed demonstrating lymphocytic lobulitis. What is the most appropriate management? I'd say this is the first time I've heard of lymphocytic lobulitis first.
That's why I'm doing this question. So you're just gonna guess, right?
I would go with excisional biopsy.
Okay, I'm glad you didn't pick mastectomy.
C.
So lymphocytic, why isn't it letting me, have I already done this question? So lymphocytic lobulitis, oh, I see, it didn't let me pick the question because this is the right answer, okay, or that answer. So lymphocytic lobulitis is diabetic mastopathy. Now, if they had said diabetic mastopathy, you would have picked blood sugar control likely, even if you didn't know what diabetic mastopathy was. But diabetic mastopathy is an inflammatory process that occurs in the intralobular stroma in type 1 diabetics. And, you know, an ill-defined hypoechoic area with shadowing and irregular margins on ultrasound, man, that's worrisome. And that's why you went for a biopsy. And that would have been appropriate, except this is a type 1 diabetic, and her core biopsy shows this lymphocytic perivascular inflammation, all this jazz here. So it's not pre-malignant, and it says 60% of diabetic mastopathy recurs after excision. Therefore, excision is not recommended. So it's some kind of autoimmune thing. And blood sugar control is recommended, not really because it does anything for diabetic mastopathy. It's because blood sugar control is always an appropriate thing to do in a diabetic. So if you were a test taker specialist, you may have gone for blood sugar control. Okay. Let's go look at, okay, here's a common problem. A 30-year-old woman with bilateral axillary swelling presents to your clinic. She states she first noticed the swelling during her pregnancy. Since then, the areas have remained swollen, more so during her menstrual cycle. And who's wearing their mask on the Zoom call? Okay. Anyway, she has these swellings in her armpit. They change with her menstrual cycle. And there's a picture. Okay, so let's have a PGY2 pick an answer here.
Christina was the only one on. Maybe a researcher.
Oh, a 3? How about a 3?
Oh, Bobby. Is Bobby still on?
Yeah, it's 8 o'clock. It's getting late. So.
Yeah. I see Kat. Kat's on. She's like an advanced intern. That's like a 2 or 3.
Okay.
Okay.
First of all, what is it?
I think it's axillary breast tissue.
Yeah, axillary breast tissue, or people call it ectopic breast tissue. So very good. That's a good place to start. Now the rest is just trivia about ectopic breast tissue, but some of it's important.
I don't think you need, I think A is not correct. I'm gonna go with C.
Which one?
C, answer C, although this condition is present at birth, symptoms often do not occur until puberty or pregnancy.
Yeah, that's correct. Very good. Let's see. Okay, now, the thing about axillary breast tissue, and I have to confess I've never done this, but carcinoma can develop in accessory breast tissue. And for this reason, it should be included in regular screening examinations. But if you've ever had a mammogram, which most of you have not, it's hard to imagine how you would include axillary tissue like that in a mammogram. So the method of screening should be ultrasound. So women with axillary breast tissue should have ultrasound axillary breast tissue with their regular screening. That's an important thing to do. But otherwise, it's benign and there's no reason to excise it. It can be annoying to people. And I mean, I think it's reasonable to excise it, but it doesn't get excised. Okay, we're out of time. I had a whole bunch of questions here, which I think are really good. This Society of Breast Surgeons comes up with these questions, and the reason I like them is because they're designed for, you know, the average surgeon taking care of breast complaints, and they're good consensus recommendations and good strategies. And if any of y'all want to do these questions, I'd be happy to do them with you sometime. We can do them in my office or in some other settings. There are 30 of them for benign breast conditions. Okay, that's all I've got. Y'all have a good day.
Dr. Martin, that might not be a bad idea for like a Tuesday or Wednesday morning. We could just do 15 questions as the academics for that day or something.
Yeah,
Oh, yeah.
I'd be happy to do that.
Yeah.
There, I mean, with this this whole program, there, how many questions? There are like 350 of them or something like that. There are a million of them.
We'll just do breast for the next 3 months.
Yeah.
Great. Everyone would love that.
But the benign breast disease are good ones because those are things you see every day, all day long, or at least I see them every day, all day long in the clinic.
Yeah, I would say that anybody that at a MEDAC, you're going to end up as a general surgeon seeing a lot of this stuff. So you got to know this stuff.
Yeah.
All right, Dr. Krell, your show, or Dr.